The lowest levels were in progressive patients. Okay, so those patients that slowly progress have a lower level. Patients with benign and relapsing, okay, had the highest concentrations of the MS population. So now we're setting up a hierarchy. Your primary progressive is the lowest, your secondary progressive is in the middle, okay, and your relapsing remitting is on top in terms of concentrations. Now, here's the interesting. This pulls out something. During one of the beta seron studies, they showed that the beta endorphins increased. Now we're going to see that that's exactly what naltrexone does, but naltrexone does it a whole lot more effectively. So there's some correlation here. There's something that, some scientist, over there should be studying, and that is this beta endorphins. They've already approved a drug that does this. Well, I believe our drug does it a whole lot better. It was found that MS patients during a stable phase of the disease had low levels compared with age-matched control subjects. Same thing, different way of saying it, different study saying it also. Beta endorphin concentrations were lower in patients with magnetic resonance imaging evidence of ongoing MS activity. So we looked at this before. Again, it was a subjective analysis. We looked at patients that we thought were having an exacerbation, and their levels were higher. Now we're looking at magnetic resonance, or MRIs, and it's saying that the concentrations were lower. And this begs the question, when did they do the MRI? Had we caught up with it? Had those beta endorphins caught up with the disease process? And we have no data to support the hypothesis that the decrease in beta concentrations precede the onset of MS. So we don't know whether they go down. We just know that as the process goes on, they will go up. Now for the T1, now we're tying this all together, okay? I hope you're following it. Okay. Beta endorphins can affect the helper T cell balance, that Th1, Th2 shift. It has been shown, and I'm going to skip through this because this is pretty dry. It's been shown that with that interferon study before, that there was a T1, T2 shift, not a real big one. And if you compare the data, a whole lot less than what they found when people were on LDN. We're saying the same thing over and over again. It's a take-home message. Beta endorphin concentrations in MS patients were significantly lower than those found in healthy controls. There's a difference. Beta endorphin concentrations were lower in patients with MRI evidence of MS activity, but were we trying to catch up here? I don't know. Good question, Skip. Okay. We know that it's shifted it to the second, or to Th2. There was, and I can't say her name, Garoni, I believe is how she says it. This is the infamous or famous Italian study. It was an open label, uncontrolled, clinical 6-month trial. And what all they were doing was assessing safety and tolerance. This is like between a phase 1, phase 2 study. They were trying to make it a phase 2, but they only got phase 1 out of it. Okay, 35 patients were enrolled, or 35 patients completed it. That's 87.5%. So remember, we go back and we go, how many people dropped out and were there reasons for it? Well, there were. 5 patients terminated prematurely. Only 1 patient out of the 40 that were enrolled had a progression of the disease. okay? And there's these scales, the EDSS scale, and, you know, I can remember a study done on a product called Procarin, and they used the EDSS scale, and the Multiple Sclerosis Society said they used the wrong scale. But here we are back with this study, and we're using the same scale. The measuring sticks are a little broken too because of the subjective analysis that's involved. Okay, so at the end of the study, only one patient experienced a progression. 35 patients remained unchanged compared to baseline. Now, what does that say? Why do we use low-dose naltrexone? We use low-dose naltrexone to prevent progressions or exacerbations. That's all we're doing. We're not curing anybody. We're not looking for symptomatic relief. We're looking to slow down the progressions and to stop the exacerbations. That's what we're doing. And guess what? Even though this was a phase 1 study, sort of into phase 2, 35 patients effectively took this drug. Okay, now this is interesting, a significant reduction of spasticity. For those of you who have gone and used the protocol that we actually developed 10 years ago down in South Florida to take care of side effects, it seems like when people go from 3 milligrams to 4.5, there's an increase of spasticity. Now, they used a 3 milligram dose, so maybe 3 milligrams is right, maybe not. But we do know, I know from personal experience, that it always happens, or when it happens, it is always during a dose increase. In this study, the levels remained up after 1 month, or 1 month after the end of the study. Is there some prolonged benefit to this? The question is, do we take this at bedtime? Do we take it sustained release? All of those questions. Well, this raises that question again. You know, is it important to take it at bedtime? In my humble opinion, it is, because the endorphin cycle is diurnal, it's not circadian, and you have your first zenith in the middle of the night, which also means to say that you have your first nadar just before that zenith. Nadar is the low level, zenith is the high level, and this high level comes out in the middle of the night. It generally will happen if you look at sleep cycles. It'll generally happen when you're supposed to be dreaming too. The reason why we get vivid dreams. The quality of life parameters were improved, but none of them at a statistically significant level. Well, let's talk about that. Is that a statement of fact? Well, I would question the significance. Nobody had an exacerbation. Nobody had a progression. I would say if I was an MS patient, that would be a pretty significant factor in my life. As a matter of fact, when we look at some of the data that we have captured, it's probably one of the most important things. You know, you look at our data and you compare, you know, number of exacerbations with quality of life improvements, and they're right around the same ballpark. B concentrations increased in 3 months, remained elevated up to 1 month after therapy. So it took about 3 months for these beta endorphin levels to go up. Now, that's no problem if you're not having an exacerbation. If you're having an exacerbation, that's sort of a problem. So what is the take-home statement here? I don't believe, in my humble opinion, that naltrexone will solve or resolve an exacerbation. That's why when people call me, I tell them to do a steroid burst for a week. We know that works. It lasts up for a month later.